talk will be about ablation and pediatric arrhythmias, and to make it simple and to the point, we'll start with two case scenarios.
عايز يقرب شوية.
So our first case is 6-year-old male patient presented with a 2-month history of effort intolerance, dyspnea and mild exertion. He had been previously healthy and active. No history of misleading fever or upper respiratory tract infection, and no past history suggestive of structural heart disease. And the family history was relevant. Chest X-ray showed cardiomegaly and echocardiography revealed dilated cardiomyopathy with a fractional shortening of 20%. Actually, this patient was treated in our site institution as an idiopathic dilated cardiomyopathy and anti-failure medications. And then referred to our institution for further management. At our initial evaluation, his weight was 18 kilogram and his heart rate was 160 per minute regular. Cardiac examination revealed cardiomegaly, and a new echocardiography revealed dilated cardiomyopathy with fractional shortening even worse than before, 50%. And this the echocardiography, as we see here, it's the LV is markedly dilated and there is a moderate hyperregurgitation. So what's the missing in this case?
ECG.
This case was seen outside and diagnosed by clinician or pediatrician as a heart failure and referred for echo, and echo diagnosed the patient as dilated cardiomyopathy and was following actually for 2 years for this diagnosis and was not adequately respond to treatment. What was missing is a 12-lead ECG for this patient. So when we did a 12-lead ECG, as we see here, the heart rate was like 160 per minute, but if we proceed in a systematic way for ECG interpretation, we will find here the P wave, it's deeply inverted in the inferior lead in 2, 3, and AVF, as you see here. So this is not a sinus rhythm. This patient actually has an ectopic atrial tachycardia. And this actually is a good news because this ectopic atrial tachycardia is the cause of this dilated cardiomyopathy, and if we treat this arrhythmia, the patient will have a normal heart. So the eye doesn't see what the mind doesn't know, and this applies to the ECG. So ECG interpretation in a systematic way is very important for diagnosis. The second case is a 10-year-old male patient known to have a dilated cardiomyopathy and also was referred to our hospital from outside the institution. And he has NEHA class 2 and he's on anti-failure medications. Chest X-ray also the cardiomegaly and echocardiography revealed the breast LV function. So at our initial evaluation, his weight was 40 kilogram and his heart rate regular 100 beats per minute, and his cardiac examination revealed cardiomegaly and the new echocardiography. We found the dilated LV, but there is like a regional wall motion abnormalities in his interventricular septum. So as we see here, this is the left ventricle is dilated. And this is the interventricular septum. There is a part of the septum, the nasal part here. It looks like a paradoxical or abnormal septal motion. So again, this patient was treated as a dilated cardiomyopathy and has no ECG. So this is the 12-lead ECG. As we see here, this is a wide QRS and very short PR interval, which is called WVW or pre-excitation syndrome. So in those patients, actually they have an accessory pathway, and through this accessory pathway, part of the electricity go to the ventricle. So part of the ventricle excited before the other parts. So with years, it leads to LV dysynchrony and dilated cardiomyopathy. And again, in this patient, if we ablate the accessory pathway, he will have a normal heart. Again, to confirm the diagnosis that this patient had cardiomyopathy due to the presence of accessory pathway. We did speckle tracking, which is more sophisticated model of echocardiography. As we see here, it shows that the global longitudinal strain in this area is markedly affected due to the presence of the accessory pathway. So for those two patients, we decided to go to the cath lab to do electrophysiological studies and ablation. And this is the picture of our cath lab, a lot of monitors on the screen. So what are the indications of electrophysiological studies in children for evaluation of sinus node dysfunction in patients with sinus node dysfunction? In patients with, not in all patients with supraventricular tachycardia, but in those patients with frequent or poorly correlated SVT. Also in some patients who prefer catheter ablation than pharmacological therapy. Patients presented with a wide QRS tachycardia for proper diagnosis. Assessment of patients with WPW, because those patients have a risk of sudden cardiac death. And also in a group of patients with tachycardia-induced cardiomyopathy, like an ectopic atrial tachycardia. And also in the investigation of cases with unexplained sudden cardiac death. Usually we do the cases under general anesthesia and we use the femoral axis for introduction of our catheters. We usually use 3 to 4 catheters, one in the coronary sinus, and one in the right ventricle, one in the high right atrium, and one to look for the accessory pathway or ectopic focus and do the ablation. How to ازاي بنشوف الكاثيترز inside the heart? We have two modes or two methods. Either we do under fluoroscopy like here. بنستخدم two fluoroscopic view, left anterior oblique and right anterior oblique, وزي ما احنا شايفين دول الكاثيترز inside the heart. coronary sinus catheter, الهاي رايت atrium, وكاثيتر هنا بنلوكيت الهيس باندل to the right ventricle. وده شكل الانتراكاردياك سيجنالز اللي احنا بنشوفها وبنعرف مكان الاكسسوري باثوي او الاكتوبيك فوكس according to those signals. ده شكل السكرين. في another more advanced mode ان احنا بنستخدمه دلوقتي والحمد لله عندنا الجهاز بتاعه اللي هو 3D electroanatomical mapping. احنا بنستخدم سبيشال كاثيتر عن طريق المagnetic فيلد جوه الهارت بنكريت ماب زي مثلا في الحاله دي ده الماب بتاع رايت اتريوم ده السوبيريور فينا كافا ده هنا ترايكاسبيد انيولس ودي كرونري ساينس ودي الانفيريور فينا كافا وبيدينا يعني الاناتومي بيدينا بالكالر كودنج كده نقدر نعرف مكان الاكتوبيك فوكس فين ونعمل لها سكسسفول ابليشن. في الاكسسوري باثواي في الاطفال ممكن نلاقيه اراوند المايترال انيولس او ترايكاسبيد انيولس فساعات تبقى رايت سايد او ليفت سايد ففي بعض الكيسز بنضطر ان احنا نعمل ترانسبتال بانكتشر وجو انتو ذا ليفت سايد. في الاكتوبيك اتريال تاكيكارديا ممكن تكون في رايت سايد او ليفت سايد، في رايت سايد ممكن تكون حوالين الكريستا عند البيز بتاع الرايت اتريال اباندج او في ليفت سايد حوالين البلمونري بيز او البيز اوف ليفت اتريال اباندج. احنا يوجوالي معظم الحالات بنستخدم الار اف ده عباره عن الكتريكال كارنت بيبروديوس هيت عشان ابليت الفوكس. بعض الحالات ممكن نستخدم لها الكرايو واحنا ان شاء الله بلاننج ان احنا نجيب جهاز الكرايوثيرابي ان شاء الله coming 2 months. ده شكل القسطره بيبقى ليها التيب ده اللي بنعمل فيه ابليشن وبيبقى ليها الكترودز هنا اللي هي بنشوف بيها الالكتريكال سيجنالز. Again, back to our cases, we decide to go to the cath lab. الفيرست كيس اللي هي كانت اتريال تاكيكارديا احنا عملنا لها 3D anatomical mapping. هنا ده السوبيريور فينا كافا، هنا الانفيريور فينا كافا وده الكوروناري ساينس وزي ما انتم شايفين الاريا الحمراء دي هي دي بدايه الالكتريستي فدي ماشيه جدا مع الاي سي جي ان الفوكس موجوده في اللو رايت اتريال اراوند ذا كوروناري ساينس اوستيوم عشان كده البي ويف كانت مقلوبه في الانفيريور ليدز واحنا ابلاينج راديو فريكونسي كارنت في الحته دي الحمد لله كانت سكسسفول والفوكس انتهت وده منظر الاكتيفيشن ماب بعد كده لقينا ان الاريا هنا بتاعت الاس دي نود هي اللي بقت الفيرست اريا يطلع منها الالكتريستي. وهنا ده شكل الاي سي جي بيفور ده شكل البي ويف وبعد الابليشن البي ويف بقت ابرايت في الانفيريور ليدز. Actually, this patient back to normal function after 3 months of ablation. The second case ده شكل accessory pathway كان anteroceptal في right side. ده كان قبل الاي سي جي قبل وده بعد الابليشن. الكيو ار اس بقت نارو والبي ار انترفال نورمال. هنشوف الايكو بعد كده. ده هنا before ablation. زي ما احنا ملاحظين هنا ال في كان دايليتد وكان في زي septal regional motion abnormalities اختفت تماما بعد الابليشن في حاله البري اكسايتيشن. اجين برضو اللوبيتيدال سترين بالسبيكل تراكنج اتحسن جدا بعد الابليشن. كل الاريا اللي هي كان فيها مشكله اتحسنت جدا في البولز اي في السبيكل تراكنج. So take a home message, a recognition of arrhythmia-induced cardiomyopathy in a pediatric age is very important because offering an appropriate treatment leads to recovery of ventricular function. Arrhythmia-induced cardiomyopathy to be taken into consideration in differential diagnosis of idiopathic cardiomyopathy. It's mandatory to obtain a 12-lead ECG in any patient presented with heart failure cardiomyopathy. Careful ECG interpretation and proper training of pediatrician for ECG is very crucial. Ablation of arrhythmia in pediatric age group is feasible and safe. Okay, thank you.